including bad lung disease or emphysema that you really wouldn't want to put to sleep because we'd be afraid when they woke up they wouldn't be able to come off the ventilator. Again, the location of the blockage. Dr. Verena was pointing out the jawline on one of the pictures there, and if it's too high, the surgeon really can't get to it. It becomes either just impossible or very high risk. So, matter of fact, I had a patient today in the office that had a very high bifurcation lesion, and we're going to have to consider that for a stenting case. Again, the complexity of the disease, whether it's got a lot of calcium or the rock hard buildup in there, or whether it's got a lot of clot, a soft clot blockage, or one that has a lot of clot is more prone to having a stroke during the procedure. So you may want to consider that for stenting as opposed to the surgical procedure. Age of the patient. A younger patient, we may, that's in their 40s or 50s that develops what we call premature blockage. You may first want to consider that for surgery because they tend to be a better surgical candidate, and then they're actually young enough they may actually have more blockage down the road and have to have a second procedure 20, 30 years down the road. So those are some of the considerations there. Rob, you may have some other things that you think about.
Yeah, I mean those definitely, and Rob, and I also was about to ask you about your experience having trained in Ochsner and them being some of the pioneers in carotid stenting, as to when they did it and what kind of safety record, and what would they typically, being in a premier institute offering that, what were you exposed to carotid stenting in your training?
During my training, the carotid stenting was basically in its, I don't want to say experimental stage, but in its trial phases. It was one of the sites that was chosen to study this particular procedure. Even at the beginning stages of putting in carotid stents, the procedure proved to be very safe. And my best recollection, I can't recall really any major complications that occurred. Patients always seemed to fare fairly, well post-procedure, and in most instances discharged the next day. The procedure, I think, is developing into its own. It's proving to be a very safe procedure and a very effective procedure, and also, a viable alternative to a surgical approach. And as we keep reiterating, as patients get older, the population gets older, they acquire much more complex and numerous medical problems, and that kind of compounds the person's potential risks for surgical, correction, given the fact that you're going to be under general anesthesia, or put to sleep, so to speak. Carotid stenting, you're not put to sleep. You're basically given mild sedation and remain comfortable throughout the entire procedure and awake during the entire procedure. So it's somewhat of a different approach to treating, a long-standing problem in a very high-tech and advanced way.
Well, that's really exactly where we have seen, and being that from the roughly about 10 years of my training, when I started off and doing interventions and all that, my experience has been roughly close to 10 years. And I think that I remember the days when we started doing carotid stenting without the use of this so-called distal protection filters. And I wish I had the little filter to show it. So filter is nothing but a tiny umbrella-like device, which is at the tip of a wire, which can be lodged distal or further up from the blockage. If you consider a blockage is here, you can slowly track this tiny filter in a catheter and deploy it slightly above this, like an umbrella protecting it. So when you go ahead and start doing your procedure, which entails balloon angioplasty and subsequently stenting, the biggest concern, as we are talking about, particles breaking loose when you put a balloon or a stent or dilate them to high pressures, which is part of the treatment of carotid stenting. Historically, the concern has been if the particles break loose and go up to the brain, if there is no filter or protection device, we will defeat the whole purpose of doing the carotid stenting. So, but to me, the groundbreaking event in carotid stenting has been the development of filters of different varieties, including the typical umbrella device, which is still probably used 90-95% of the time across the world when they're doing carotid stenting, has simplified and really emboldened the cardiologists and other interventionalists, namely vascular surgeons and interventional radiologists, to go on and take care of this more and more. And we are happy at our institution, Opelousas General, to have offering this with initially with Dr. Khan, who was my predecessor, who's been doing it, and after him, in my close to 5 years of my experience here, we have done this procedure hundreds of times pretty safely and effectively. To me, it seems like, again, surgery has a definite place. All of us know that surgery has been there for 40 years. It is a clear-cut, it has its clear-cut space. But I think as time goes by, we have studied the carotid stenting in multiple different scenarios. If you look at it initially, the carotid stenting, even now, is only done in the highest of the risk of patients. I mean, you take a whole group of patients, you take the sickest of the patients, you take the oldest of the patients, you take the patients with highly complex blockages who are considered inoperable and historically have been refused for surgery. Those are the patients carotid stenting was considered initially. But as time went by, with thousands of patients being studied in different settings, namely the more healthier, relatively young patients who still had some limitations to surgery, but not absolute indications. It only makes sense that if you take a patient and have a lot of risk factors and you do a procedure with absolute or like excellent safety comparable to surgery, that will gradually be applied to the more healthier subset of patients, because they will be demanding this, because it's a lot simpler alternative to carotid surgery in terms of a procedural thing. You go in there and once you deploy the filter, typically a non-complex procedure, the ballooning and stenting is under 10 minutes and the patient is back in the waiting room in half an hour, 40 minutes, and typically goes back home next morning. Of course, all this clearly comes with years of experience with the team as well as the operating physician. And the biggest risk factor, of course, when we discuss about stenting is the prevention of stroke during the procedure. That is the #1 risk factor. And of course, the case selection for carotid stenting. Some of the cases which are young, we don't do it, and we went over this. But the case selection is a little more sophisticated technical process which our audience may not benefit that from. But I think carotid stenting is here to stay, in my opinion. And you take a wide variety of subjects. Right now we are in the middle of the ground. We are happy to have several investigational protocols. So our ability to enroll and do carotid stenting is a little more broad-based than an average interventionalist out there. So we are happy to welcome patients for any opinions regarding carotid disease. And we also have very able surgeons in our institution, so not to take anything away from them at all in this case. And tell me, how do you tally these two? Again, you said this, but in terms of a patient safety-wise, and I tend to give them anywhere 1 to 3% if it is acceptable. Risk is considered anywhere up to 3% is a maximal amount. When I say the risk, we're talking mini strokes, and we're not really talking about massive devastating strokes. What has your experience been with carotid stenting, Clay?
I really can't add much to that, because that's been my experience. It is a very safe, quick procedure. Rob was talking about the anesthesia with it, and you can correct me, but I remember in the early days when they were doing the first ones, they actually wanted the patient wide awake, talking and counting while the stent was being deployed. So it was definitely a low anesthesia type procedure. I think now they're giving them a little bit more conscious sedation once they realize that there's the acute stroke is not as big of a risk as it was once thought to be when they first started putting them in. Again, the safety, the swiftness which it can be done, and I've seen many times in our office where somebody has ordered a CAT scan, saw the patient that morning, they went up to CAT scan, we looked at the CAT scan around noon of that day and called the patient back and said, come back, there's a 99% blockage, and you've gone in that afternoon and they're fixed, and the next morning going back home again. So less than a 24-hour period of diagnosis to being totally treated and back home again, and that's quick. You don't get that with surgery. So.
Sure, Rob, any final remarks on this before we are approaching the last few minutes?
I think with, it's been around long enough to prove itself. It's certainly, it's as good and in a lot of instances better than a surgical approach. But it's definitely a very safe procedure. It's accessible basically throughout the country, and as Dr. Verena said, available at our institution. And we always welcome second opinions for patients, and if they have any questions or concerns for us to consider them for this, we're happy to do so.
Well, that's really the thing of it, is that and finally in tonight's discussion is about bringing awareness to patients about carotid disease as an entity, and why people with the right type of risk factors who should be concerned about having carotid disease are the patients with the typical cardiovascular patients that have the other risk factors of heart problems, high blood pressure, diabetes, high cholesterol, smoking, and inactivity, and bad diet, and so on and so forth. These are the patients that are at risk for it. So the burden is predominantly on us physicians, starting at the level of internists, starting at the level of cardiologists, and finally the specialists that end up taking ultimately care of it historically have been vascular surgeons and cardiovascular surgeons who operate on it, and cardiologists and interventional specialists like radiologists who don't operate but do the stenting, as we were just discussing about. So, and we also touch base about the diagnostic modalities. In the right patient, the diagnosis of carotid disease is a fairly simple office-based type of procedure, such as an ultrasound. Of course, starting with a clinical exam, and you suspect that there is a blockage, you go on to do an ultrasound. And then if the ultrasound is positive, certainly in our opinion, the CT scanning certainly has revolutionized the speed with which, not only the speed, but the safety with which we are diagnosing and absolutely pinpointing the severity of the blockage and making a decision within hours when the patient approaches us with this disease. So it really has come a long way since the time when we were training. You do this, and then you would set up with a cardiologist, do an angiogram, and then wait for the angiogram to be read, then make an appointment with the surgeon. And not uncommon for patients to actually, in some unfortunate instances, have a stroke when the time they're waiting to have for an appointment with a surgeon to have endarterectomy. And of course they would go there, sometimes they would say, well, you're not suitable for this, go back to this, or just take this or that. But I think in bulk of the instances, in the right candidates, in this day and age right now, we have plenty of options. Bulk of the options, of course, in asymptomatic simple carotid disease is medical therapy. And the second option, of course, still bulk of the patients that we see are the relatively young, healthier, low-risk patients are referred for surgery to a large extent until we have more data saying that carotid stenting is safe in all patients across the spectrum. Surgery still remains a very strong type of approach for treating carotid disease. And finally, we talked about carotid stenting as a modality which has evolved in the past 10 years or so as a very safe, very efficient, effective treatment with a long track record. And I'm very optimistic that is here to stay, and we will be offering this procedure for years to come. And I'd like to thank our audience for tuning in for our night show, and we'll come back again the second Tuesday of each month, bringing you lively cardiology and cardiovascular topics. You're welcome to call in anytime and tune in for our repeat shows throughout the month. Thank you.